Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Professor Adrienne Scott of the Wilmer Eye Institute, Johns Hopkins University. Adrienne, welcome back to Retina Synthesis.
Carmen, thank you for having me back. It's an absolute pleasure to be here with you.
You recently published and discussed a paper about the real-world treatment of proliferative diabetic retinopathy in the world in which we had Protocol S. Can you tell us a little bit about your study?
Certainly. So, the team and I looked at the Vestrum database in a retrospective fashion, and we established a protocol comparison based upon what was done in Protocol S of the DRCR versus kind of what's been done in community practice since the publication of the 5-year results from the DRCR Protocol S. And that protocol, as we know, taught us that anti-VEGF monotherapy was non-inferior to pan-retinal photocoagulation for treatment-naive PDR. And we sought to look at that years after the results were published to be able to answer the question, well, who is following this protocol? Are these patients being followed per this protocol? How does that particularly change outcomes for those particular patients? And essentially, what are the characteristics of the patients that end up with a little bit more adherent to the protocol? And what is the variation within the protocol set by the DRCR? And then what are the characteristics of those patients who have better or worse outcomes, including loss to follow-up?
So, what was the top line finding of your study?
The top line finding is that in community practice or real world, as we like to say, um, practice patterns are quite varied regarding anti-VEGF. I think most of us essentially do some combination of treat and extend or even PRN or as needed treatment for proliferative diabetic retinopathy and likely institute some sort of combo therapy. So I think there's very little strict adherence to the protocol practice patterns from the DRCR Protocol S.
What was Protocol S's recommended anti-VEGF treatment modality?
So they used ranibizumab and started with baseline dose and then 3 doses afterward. We call them sometimes loading doses or induction doses. And essentially, after that point, there was a treatment period allowed to be extended for activity of proliferative diabetic retinopathy as judged by the investigator. Patients were also randomized treatment naive PDR to pan-retinal photocoagulation as well, and then the outcomes were compared between those two groups.
So, in your study, how often were patients getting four anti-VEGF treatments?
Yeah, I think it is quite varied, and very frankly, it's kind of all over the place, is what we found. So that just basically means there were physician factors, there were patient factors, and I would say probably about maybe only 30%, 30 to 40% of the time, patients were getting treatment that kind of more adhered to the DRCR protocol S. And as you would imagine, patients with diabetic macular edema, in addition to the proliferative diabetic retinopathy, tended to be treated a little bit more adherently to the Protocol S application of anti-VEGF.
What were the patient characteristics that varied with treatment?
Sure. So the patients that ended up being a little bit more adherent to anti-VEGF treatment tended to be patients with diabetic macular edema, a little bit more of the younger demographic. Patients who were over 80 years old ended up being treated a little bit less with monotherapy with anti-VEGF and had slightly higher rates of loss to follow-up. Patients with commercial insurance tended to be um, a little bit more held to the adherent regimens from Protocol S with monotherapy, and patients with governmental insurance, such as Medicaid or Medicare, ended up without necessarily being as adherent to the DRCR Protocol S.
Uh, so, in the real world, pan-retinal photocoagulation is still a very important tool.
Yeah, I agree completely. And I kind of wanted to make the point with the study is that patient factors and practice factors and no treatment is as good as the patient and the doctor's ability to apply that treatment, no matter what a particular protocol says. Patients in certain studies are very carefully selected, enrolled, recruited. You have somebody whose literal job it is to call and make sure that you follow up if you're in a study. And patients are cared for very exquisitely, I think, regarding treatment regimen and adherence to such in a protocol. But when you get out there, life gets in the way. So what does that mean for a diabetic? You have other things happen. So you have patients with comorbid diabetic illnesses, hospitalizations that keep them from being as adherent to therapy. You have patients that feel like they see well, so why should I follow up? You have also the social determinants of health that sometimes get in the way, such as getting access to care or being able to afford certain therapies. So the high kind of level finding from this protocol is you really have to individualize treatment based upon what works best for the patient and importantly what the patient is able to adhere to regarding their treatment regimen. And the discussion has to be had. Just because anti-VEGF monotherapy was shown to be non-inferior doesn't necessarily mean it's best for every patient.
So can you give me a sense of what percent of patients were lost to follow-up in this study?
Sure, absolutely. So just to qualify that, there were obviously the limitations from a retrospective study, and this was a Vestrum a database that gave us lots of data regarding patients, but we, do acknowledge that there may be, some visits or patients may have switched practices that may not be picked up. But loss to follow-up was as high as, 30 to 40% in some patients. And,
Mhm.
it varied depending on demographics. Again, the patients with diabetic macular edema tended to have a little bit better follow up. And you kind of think about, well, those are the patients that may have visual compromise and be a little bit more held to be adherent to protocol S standards. Interestingly enough, you also found that smokers tended to be have a little bit worse outcomes, a little bit higher rate to follow up, and then worse complications such as neovascular glaucoma, vitreous hemorrhage, or things like, detached retina.
So how often do you think panretinal photocoagulation is used these days?
Yeah, that's a really good question. I think that it is varied. And in talking with colleagues, even I've had people come up to me and say, hey, if it were my eye, I would want monotherapy with anti-VEGF. And I've had colleagues, retina specialists come up to me and say, hey, just give me the PRP. So I think that um, I probably say it's probably a little bit more like 50-50, maybe 60% for the PRP and maybe less with anti-VEGF monotherapy. And then quite frankly, I think most of us institute some sort of combination therapy of anti-VEGF and panretinal photocoagulation. But, you have to have, it doesn't take very many, one or two patients where you have good intentions and they have all the willingness to start on anti-VEGF monotherapy, but then for whatever reason they aren't able to follow up or they aren't able to get the injection treatment that you adhere to that regimen. And it kind of all of us, I think, have these patients where we think, gosh, you know what? I can quiet down this PDR with a good round of panretinal photocoagulation and potentially, there are, certainly bad outcomes that can happen with PDR. You can have some complications as well with PRP. But in my hands, and at least from my understanding and my experience so far, it tends to be a little bit more durable and forgiving about treatment schedule.
So what's your approach to a new patient with proliferative retinopathy these
Yeah,
days?
that's a great question. It's such a mixed bag. I mean, I have the conversation with the patient and kind of the discussion about, just to tell them everything that's out there because they have, for example, chat groups and, they have, oh, somebody online had a pan-retinal photocoagulation or PRP and felt like they lost vision and, so there's all kinds of perceptions about, treatments and various effects. So I have to really try to have a very candid discussion with the patient and say, here are the options. If a patient has diabetic macular edema, I absolutely will start with monotherapy with anti-VEGF to try to get the diabetic macular edema controlled and then decreased. And then once I do improve that DME, then I may follow up with some pan-retinal photocoagulation placement as well, once the DME I feel like is well treated. But it's a conversation I have with the patients, and oftentimes they look at you and they say, "Oh, doc, what would you do?" And I say, you know, um, if they have diabetic macular edema, I would recommend anti-VEGF. If they're treatment naive, I would have a talk with them about what are their abilities to follow up. Can they come see me every month, every 6 weeks? And if they have any trouble or I get the sense that it's challenging for them to make appointments, I'm saying, hey, I recommend pan-retinal photocoagulation.
Yeah. So in the eyes that have combined therapy, is the extent of panretinal photocoagulation less than in eyes with PRP monotherapy?
Well, it's a good question. I mean, I think that kind of depends on how everybody has a little bit of a different PRP strategy. I mean, I think that with the modern lasers, they can be applied with precision. I often use an ultra wide field fluorescein angiogram to help me guide, for example, areas of non-perfusion and try to treat based upon what I see on the retinal imaging as well. So I think that all the patients who have PDR need a really good, solid PRP. I don't necessarily treat very posterior. I think there's some patients that were treated had vision loss from a really tight posterior PRP. But I want to make sure I spare the arcades and the macula to make sure they get very good vision, or at least they can maintain their vision. But overall, I think a good PRP, typically I'll divide it up in 2 sessions and I use the angiogram as a guide.
So it's really all about patient compliance.
It so is. It so is. And then, really, frankly, I think it does have come down to sometimes we as the retina physicians may feel like, gosh, it's maybe, either one way or the other. It may be a little bit more straightforward for us. We can put it in an injection a little bit quicker than we can place a pan-retinal photocoagulation session. Alternatively, you also have the elephant in the room that's in with all of us, meaning the payer, meaning will we be able to get subsidized treatment for anti-VEGF therapy for that particular patient?
Hmm.
So you're exactly right. I think it comes down to the particular patient and their circumstances and the ability to follow up for the treatment that you recommend.
Well, this has been a great discussion about Protocol S meets the real world. And I think that you've provided us with some real world guidance.
Yeah, it's fascinating, and thank you so much for allowing me to discuss this. I think kind of the point of what I wanted to try to put out there is that we kind of treat all over the place, and we have good evidence base that we use, but instead of kind of adhering as strictly to evidence base or whatever clinical trials um, are published, we do that. But then, kind of once we get out in the clinical practice or real world, we kind of extrapolate quite a bit. And so that was really one of the kind of the points that I would like to make with the study is that it really comes down to what's best for the patient and the doctor, and the patient and the doctor and their relationship and availability and ability to do the therapy that you intend.
Well, thanks a lot for your help today on retina synthesis.
Absolutely my pleasure, Carmen. Thank you very much for the invitation.